My name is Elena Pacheco, and today I'm going to be doing a presentation on the ligament and tissue healing of the acromioclavicular joint. This is a project that we've been working on. It's been me and my three colleagues or peers, Nicholas Abbott, Lin Yao Fu, and Keith Pesco. And today we're kind of just going to explain what the tissue healing is like for that ligament and that joint in a grade 3 separation. So there are two mechanisms of injury. There's a traumatic mechanism of injury where it's excessive force or sudden axial load applied to the shoulder. This usually happens in an adducted position. And basically it's just a lot of pressure or load applied straight to the acromion. And this trauma is the primary mechanism by a vast majority for grade 3 sprains. As for chronic, it's an intrinsic mechanism of injury as a result of osteoarthritis or repeated microinjury that's gone untreated. So this is kind of usually gone unnoticed without looking at radiographs or anything of the sort to kind of diagnose it in the past. So the Rockwood classification is the distinct classification of AC joint separations, and it kind of shows the patterns of the injury. So with a type 1, it is essentially a separation or a disruption, a mild disruption of the AC joint, which is marked by like very minimal instability. Type 2 is a full separation of the AC joint, but the CC joint is still intact. The type 3, which is what we're kind of focusing on today, is a complete disruption of the AC joint and the CC joint with a slight superior translation of the lateral clavicle. Type 4 is similar, same disruption of both sets of ligaments, but this has a posterior translation. Type 5 has same thing, disruption, but with a marked superior translation. And then type 6 is an inferior translation where it goes into the subacromial space. As for statistics and epidemiology of this injury, as I said before, type 3 is the prominent grade of this type of injury. And so it accounts for about 40% of the AC ligamentous pathologies. As for like the mechanism, as I said before, it is usually a traumatic injury. And so 42% is sports related, whereas 31.4% is usually motor vehicle related. Males have a prevalence that is 5-fold in comparison to females. This is likely due to the increased participation in contact sports for men. As well as motor vehicle habits and things that are more likely to kind of damage this region of the body. And then just over 50% of AC joint injuries occur in 20 to 39 years old. This is once again because of the maturity of the bone and the ligaments and everything, but also because of the likelihood for kind of traumatic injuries. So this is the case that we are using to highlight our injury. And so I'll take a second to read it. All right. And I'll kind of move on to understanding the variables of healing that go with this case and with our injury. So variables of healing, we have age and smoking. Both of these decrease the tensile strength and the stiffness of the ligament. And so as there's less tensile strength and less thickness and stiffness, it's a higher likelihood for either degenerative or just in general issues with healing. As for smoking, it's an important factor to include. However, there's a lot of literature that's mostly on animal models because of like the ethical boundaries with testing on humans, but this is definitely important to acknowledge. For Case-specific variables, there's hypermobile Ehlers-Danlos syndrome, which is a connective tissue disorder. And so it kind of applies to all of the connective tissues that we'll hear Keith speak about in the next section. But there is definitely a large impact on this syndrome with the healing and the actual organization of tissues. Alrighty, I will hand this over to Keith and he'll get you started on the tissues.
Alrighty, so I'm going to be talking about the overall structure and function of a ligament and all the components of it that make it up, and their roles as well. So just a brief overview. A ligament is organized in multiple layers of connective tissue that contain an extracellular matrix as well as resident cells within it. As we can see on the bottom left-hand corner of the screen, you can see that organization. And then the dry weight of a ligament is contained of about 20% of type 1 collagen, about 1% elastin, less than 3% of proteoglycans, and then about 1 to 2% of glycoproteins. And then as a reminder, it's going to be referenced throughout this presentation. On the bottom right is the load relaxation curve that a ligament will go through when load is applied. And so going on to collagen. So collagen initially is going to be synthesized through fibroblast. It's going to originate as a procollagen molecule, then secreted into the extracellular space, and where the enzyme lysyl oxidase will then begin to organize it into fibrils and then fibers, which we can see on the bottom right hand of the screen. And then this enzyme is also going to mediate the cross-link formation between the collagen fibers themselves. And so this cross-link formation is going to be what gives the collagen its incredible strength, especially during maintain its rigidity during tensile load. Going on to elastin. So elastin will give compliance and support during multi-axial deformation, such as shear and rotational forces. This characteristic is primarily from the cross-linking or interweaving of the elastin network amongst the collagen, as well as ground substance of the ligament. In a simulation, there was a ligament that had an elastin content ranging between 0 and 33.5%. And a shear force was applied to it. And the results showed that there's an overall decrease in collagen load, about 65 and 89% respectively. In another study, they reported that elastin supports nearly 4 times the stress as compared to collagen within the toe region of that load relaxation curve. So this shows the important characteristics that collagen plays during load application to the ligament. As for proteoglycans and glycoproteins, there are many proteoglycans within a ligament. They each have their own specific functions. And some that are commonly found in ligaments are the ones listed: dicorin, fibromodulin, as well as biglycan. And these proteoglycans are primarily responsible for extracellular matrix assembly as well as cellular signaling. Proteoglycans are a very polar molecule, and so with that, they're very hydrophilic, and so they have great water binding capacity. This is what helps with the ligament's elasticity, viscoelasticity, to help dampen forces that are applied to it. As for glycoproteins, glycoproteins are found on the surface of the cells and the plasma, embedded in the plasma membrane, and they have many intra and extracellular functions. Some of which are ECM organizers as well as cellular transport. Some of those are fibronectin, laminin, and fibrinogen. And then some contribute to the elastic fiber development and organization. These will be fibrillin and fibulin. Going on to the biomechanics of the ligament. So ligaments have nonlinear mechanical behaviors and are relatively compliant under low load. Depending on the stresses applied, they're going to have different mechanical characteristics depending on the forces that are applied to it, as we can see from the different mechanics of the components that was discussed earlier. ligaments also have a viscoelastic component, thanks to all the components talked about earlier within the extracellular matrix, as well as the elastin and collagen. And then, as Nick will talk about later, the tissue will continue to absorb stress until there is tensile failure. As for neurovascularity, most of the neurovascularity is going to be on the epiligamentous tissue, and that's where that plexus is going to be. And there's very minimally some in the deeper networks of the ligament itself. During development, there's a significant contribution, but as the ligament matures, that it is slowly going to just be primarily on the outside of the ligament. As for the extracellular matrix, it primarily facilitates information transfer and coordinates tissue response to stimulus applied to the ligament. We're going to have fibroblasts that are going to be connected via cytoplasmic extensions, or if they're directly connected or directly next to each other, they're going to be connected via gap junctions. These gap junctions are very important to see how a ligament responds when there's biomechanical or biochemical information that is applied to the ligament, and there's able to be a direct transfer of information between those cells. Lastly, for proprioception and mechanoreception, joint capsules, ligaments are going to be innervated by Ruffini endings, Pacinian corpuscles, Golgi tendon, like organs, as well as free nerve endings. There's going to be afferent proprioceptive information from muscles, ligaments, tendons, as well as cutaneous receptors that are going to be processed within the CNS. And there's also going to be information from the mechanoreceptors, which are going to send neural signals to the CNS. And this is going to be reflective of the amount of tissue deformation that the ligament is experiencing. And these are primarily going to be occurring in the medial and meniscal tracts, as well as the spinal cerebellar tracts. And so once this information is processed, it is going to be coming out the alpha motor neuron to the affected area, and it's going to result in proprioceptive, a kinesthetic sense, a reflexive muscle contraction, or a regulation of muscle tone. And so Nick is going to now take it away.
All right, guys. So for the next section, so now we're going to be talking about basically the injury itself and how the ligament is affected. So to start us off with pathology of the injury, as previously mentioned, when we're talking about the Rockwood classifications, so our injury is a type 3 Rockwood, which is going to specifically be an acromioclavicular ligament tear, complete tear with 25 to 100% superior clavicle displacement. In order for it to be more than a grade 3, it would have to be over 100% displacement. So that's why it's rated as a grade 3. And additionally, to characterize the injury further, it would be an extrinsic injury due to the trauma experienced in the ski accident. For it to be an intrinsic accident, it would have to be due to biomechanical strength or flexibility factors on a micro trauma standpoint. And to characterize it even further, you could do type A or type B. And in this case, it would be type B due to the unstable aspect of the clavicle. And this can typically be seen with a visible protrusion known as a piano key sign, where if you press down on the clavicle, it will typically pop back up. And that's when you really know that you had a complete dislocation or separation of the AC joint. And this can typically lead to a lot of things such as weakness, pain, scapular dyskinesis, and other complications. And then when we get to the actual injury itself with the ligament, so for an AC tear to occur, this typically happens when the ligament is exposed to great tensions and complete failure of the ligament. For this to occur, the initial thing that has to happen is you're going to have an initial load on the tissue. And as mentioned previously, proprioceptive nerves that are within the ligament are going to be initiating these neurological feedback signals. And what this is going to do is it's actually going to activate contraction around the joint to allow it to have a tensile force. This will stabilize the joint. And this also represents the viscoelasticity expressed by the extracellular matrix, as ligaments are able to stretch much further than they are initially at resting. And this is due to the crimps in the collagen fibers as part of the ligaments. As an applied load is placed on the ligaments, they have the ability to uncrimp or slowly elongate. And this allows them to just keep gaining more and more load. And eventually, due to increased tension, as the tension increases, whether this be trauma or an applied load, eventually they will become parallel. And as this linearity increases, the stiffness will also increase. And the tissue will continue to absorb until eventually you have failure or complete tear of a tissue. With this complete failure of a tissue, your collagen cross bridges are going to completely tear apart. And if you're experiencing this complete tear, due to a ligament's already limited vascular supply, you're going to completely lose this vascular supply, and it may also completely affect the healing process. And in this case, you may also lose complete stability of the joint based off of its functions. And some consequences of that could be you could have an altered scapulohumeral rhythm now due to your unstable joint, due to inability to contract your scapula. And this could also lead to loss of rotator cuff strength and other complications. Now, after the injury occurs, when we're talking about immobilization of the ligament itself, so typically some people say that immobilization will prevent further damage of the tissue since it's going to limit the movement in the joint and prevent pain and swelling. And this is true, but it's actually worse to immobilize the tissue for a longer period of time. And this is mainly because immobilization for a long period of time can lead to synovial adhesions, also known as scar tissue, which will actually increase the stiffness in the joint, which will prolong the recovery process. It can even increase the collagen degradation and decrease synthesis of the ligament, which this will lose your elasticity and actually make it easier to re-injure the tissue. Additionally, there's a greater number of disorganized collagen fibers, which technically loses your strength as well within the ligament. So despite this current research, rice is typically still prescribed in many clinical settings. And then another effect of the immobilization on the tissue is that you lose tensile strength because the bone ligament interface where the ligament connects to the bone is also affected by immobilization. And this is because the osteoclasts are typically absorbing most of the bony ligaments of the inserts, so it's going to decrease the tensile strength. And then this is also going to lower the load to failure rate in the ligament if it ever does heal. And then there was a study done, and it found that there was 3,000 patients, and it found that rest was overused, and early mobilization showed way more improvements than extended immobilization. Now, when we get to the influence of surgery on repair, typically for a grade 3 acromioclavicular ligament tear, grade 3 is the one that remains controversial, as 1 and 2 is usually always conservative treatment, whether that be sling or some form of cast being placed. 4 and 5 is usually always operative. However, 3 is controversial. Typically, you would want to have surgery if you're wishing to regain full tensile strength, or if it's for athletes that want to be able to do constant overhead activities such as football or athletic activities. But in most cases, you're going to have a non-op for grade 3 acromioclavicular. And in this case, you're not really going to have a reconnection of the ligament. It's going to basically just create scar tissues and not completely heal back together. And this is okay as long as you strengthen the rotator cuff muscles, and it's not as good for athletes. In terms of operative, you're going to have some complications in terms of graft plates and buttons. Some things will bring you back biological factors such as grafts or sutures. But if you have plates, it is actually pretty rigid and it can lead to clavicle fractures. So there's pros and cons to non-op and operative treatment in terms of ligaments grade 3 recovery. And we're going to be passing it on.
All right. So we're going to talk about the healing timeline of ligament injury. So in the acute phase, we have the inflammatory response, which begins within minutes of the injury and continue over the next 48 to 72 hours. So in the inflammatory phase, there's the formation of platelet-rich fibrin clots, which they'll release growth factors that provides them healing and then provides a platform for other cellular events. The blood clot also attracts the immune system cells to the area and stimulate them to proliferate. After that, we have the proliferate/repair phase, and it begins when the immune cells release various growth factors and cytokines, which can last several months. So the growth factors will help the rebuilding of the ligament tissue matrix. So on the tissue side, initially, the repair tissue will be scar tissue, and then the fibroblasts will depose collagen and then slowly turn it into normal ligament tissue. And then the third phase we have is the remodeling phase, which can last months or years. In this phase, we will see the maturation of collagen. It's a slow process, and the tissue matrix will start resemble some of the properties of normal ligament tissue. So next, talk about the tissue strength and the quality of repair. So in a normal ligament tissue is primarily composed of type 1 collagen, which provides its stiffness and strength. And after injury to the ligament, the fibroblasts synthesize type 3 collagen, which is weaker than the type 1, which will lead to abnormal cross-linking, smaller diameters in collagen fibrils, and weakened tissue strength and stiffness. So the repaired ligament tissue is usually they have less densely packed collagen fibers, and there's increase of other tissues like blood vessels, fat cells, and inflammatory cells, which will contribute to it, the weakness of the tissue. The newly repaired tissue, compared to the normal ligament, is weaker, less stiff, and also absorbs less energy before failure. Some patients with ligament injury, they can have really severe instability issues even months and years after injury. All right, next I want to talk about the operative versus non-operative treatment. So as Nick was talking about, the type 3 AC joint injury is very controversial. So there's no consensus on whether to do conservative treatment or a surgical treatment. In some studies, they found that conservative treatment, they yield similar results compared to surgical treatments, with functional improvements and also patient satisfaction. But other studies showing that conservative treatment is inferior to surgical treatment because it doesn't fully restore the anatomy of the ligament. So there's still anatomical deformity, and there's high potential for residual pain, instability, weakness, and also high likelihood of arthritis of AC joint. Also, the results of conservative treatment were less favorable in patients involved in sports and work with overhead activities compared to those with a sedentary lifestyle. And surgical treatment, they result in better joint reduction, although the patient receives surgical treatment usually return to their activities slower. And they also have less residual symptoms. All right, let's talk about return to function. So our traditional understanding of AC joint injury, we're focusing on the cosmetic of the joint. The aim of the treatment is to restore the anatomy. However, recent researches try to focus on the functional deficit of the AC joint injury. So they found that high-grade AC joint injury can lead to scapular dyskinesis due to the disruption of the AC and CC ligaments, causing multidirectional instability. So the rehab program should focus on scapular control and then strengthening. For the non-op treatment, the return to activity timeframe ranges from 3 to 4 weeks. For this study was looking at professional hockey players, and 5 to 7 weeks for professional soccer players. Just a general recommendation. So our rehab protocol is the following. So first, I want to address the contraindications. So because of the Ehlers-Danlos syndrome for our patient, joint mobilization is contraindicated due to the hypermobility of the joint. And also we want to stay on the conservative side in terms of load and range of motion progression due to the impairment in tissue healing. So for the stage 1, week 1 to 4, we want to focus on the controlling inflammation. So we want to use ice for the first day, and then want to use the sling for comfort and protection. And we wanted to discontinue as soon as the symptoms have reduced to avoid immobilization. And want to use range of motion exercises. Start with gentle passive range of motion at 7-day mark to prevent stiffness without stressing the injured ligament. Stage 2 lasts from the week 5 to 12. We want to progress range of motion exercises gradually. So start with passive, move on to active assisted, onto active, and want to start postural training to improve the shoulder and scapular mechanics, as well as the stability. And want to start resistance training, targeting all the parascapular muscles. Start with isometrics and eventually progress to isotonic exercises. And stage 3 lasts from week 12 to 20. So in this stage, we will progress resistance training, increase load, volume, or frequency based on their response. And we can start some functional training to help patient get back into the activities. And that's all we have. Thanks for your attention. Hope you have a great day.